Hello, my name is Stephen Simpson, and I'm a professor of medicine in the Division of Pulmonary, Critical Care, and Sleep Medicine at the University of Kansas in Kansas City, Kansas. I served as the Screening and Early Treatment Group Head on the Surviving Sepsis Campaign International Guidelines for Management of Sepsis and Septic Shock 2021. This section is important because it is quite clear that early and appropriate treatment for sepsis saves lives. We focused our attention on how to best identify patients early and quickly and how to initiate appropriate therapy. We also spent time and effort on determining how our recommendations might work in lower resourced settings around the world. I don't have time for all of our suggestions, but I will hit what I can in this brief segment. Remember that when we say recommend, this is a strong recommendation, and when we say suggest, this is a weak recommendation. We still suggest organized screening and quality improvement efforts, and we still recommend an initial 30 ml per kilogram crystalloid bolus because there's literature evidence that these both work, and there are no papers indicating that they are harmful. For the same reasons, we still recommend that treatment for sepsis or septic shock begins immediately. We recommend against using Q-SOFA as compared with SIRS, NEWS, or MUSE as a single screening tool for sepsis or septic shock. That's because a large number of studies demonstrate that the tool readily identifies patients at high risk of death, but that it lacks sensitivity for the actual detection of sepsis. We suggest measuring lactate as a screening measure for sepsis because of its utility in the setting of infection, and we suggest using lactate reduction as a target for therapy. After the initial fluid bolus, we suggest that fluid administration be guided by dynamic parameters. By that we mean stroke volume variation, pulse pressure variation, or echocardiography in response to a passive leg raise or a small fluid bolus, for example, 4 mL per kilogram. For adults with septic shock on vasopressors, we still recommend a target MAP, mean arterial pressure, of 65 millimeters of mercury. Studies have not shown a patient-centered improvement to higher MAP targets. Our patient panel related that reduction of dialysis but no change in mortality is not an outcome of interest to them as patients. In addition, lower MAP targets in elderly patients showed no benefit over a 65 millimeter of mercury target. And finally, we suggest using capillary refill time to guide resuscitation. Cap refill performed no worse than and very nearly better than lactate in a multi-center trial. This technique is especially useful in low-resourced settings. The full guidelines are available with free access online in the journals Critical Care Medicine and Intensive Care Medicine. Educational materials can be found at www.survivingsepsis.org. Please join the conversation by joining the campaign listserv, also on the SSC website and completely free of charge. I want to say thank you to those of you who are watching this video. It demonstrates an interest in and a care for the outcomes of patients with sepsis and septic shock, and for that I am eternally grateful. Thank you very much for watching.